Welcome to the second part of the third lecture, and here we will talk about the celiac disease as one of the most commonest genetic conditions, specifically in the malabsorption syndromes in the world, and we will take it in details. Firstly, we have to define celiac disease, and we will know the basis of definition. Celiac disease is a chronic small intestinal immune-mediated enteropathy precipitated by exposure to dietary gluten in genetically predisposed individuals, causing small bowel damage. So as you see here, there are three bases for the definition of celiac disease. Firstly, it is an immune-mediated enteropathy, and it is precipitated by exposure to extrinsic factor or triggering factor, which is the dietary gluten, and this happened in genetically predisposed individual, not in all individuals. It's a chronic problem, and by the presence of these three elements, it will cause to small bowel damage. So what is gluten? Gluten protein, it's a protein found in wheat, barley, and rye, and to some extent in oat. And celiac disease presents at any time after gluten is introduced in the diet. Celiac disease has an alternative name like celiac seprum, a gluten sensitivity enteropathy, and a gluten intolerance, non-tubercle seprum, and idiopathic steatorrhea. But all of these not currently recommended now. The name is just celiac disease. As we say, gluten is a protein found in wheat. Gluten used for its elastic properties in dough and as a thickener. So that's why it's found in baked goods, in pasta, in cereals, in beers as a barley water, and even in some processed food like the French fries and canned soups. Now we will take a historical aspect of the disease. Do you know that celiac disease is a very ancient disease? 2,000 years ago, a Greek physician named Areteus the Cappadocian from Cappadocia at the southern nowadays Turkey provided the first known description of adult patients with celiac disease when he found his patient have a chronic diarrhea, abdominal distension, and a growth retardation. So the word celiac comes from Greek word, it was kailikos, which means suffering in the bowels or in the abdomen. Then in 1887, Dr. Samuel Gee, which is an English medical lecturer, gave to medical students a lecture on celiac disease or celiac affection, and this constitutes the modern rediscovery of celiac disease. Now, what is the epidemiology of celiac disease? Especially, we said it is one of the most common genetic conditions in the world. Yes, this is a fact. It is one of the most common genetic conditions in the world, with a prevalence of 0.04 to 1%. And as we said, there is a genetic predisposition. So, in 90 to 95% of the cases, there will be, in celiac disease patients, there will be expressing of the HLA-DQ2, while in 5 to 10% of them, they are expressing the HLA-DQ8. Celiac disease, it could affect all age, races, and genders, with a slight female predominance, 65% more than male. And as we say, it could present at any time after gluten is introduced in the diet. It is common in Europe and America, and thought to be rare in Central Africa and East Asia. the first degree relative family history of celiac disease, there is a strong family history, especially in the first degree relative, about 5 to 10%, but this percentage will rise to about 75 to 100% concordance in monozygotic twins, because there is an autoimmune problem. It's an immune mediated process, so there is an association with other conditions that is as a part of immune mediated processes and are problems, like in type 1 diabetes mellitus, in Down syndrome, in Turner syndrome, in IgA deficiency, and in autoimmune thyroiditis, and the percentage shown here in front of you. Now, the pathophysiology of celiac disease. What happened in celiac disease? Just to remember the definition: immune-mediated enteropathy triggered by extrinsic factor, which is a gluten, in genetically predisposed patient. So, the triggering factor is the environmental agent called gliadin component of gluten. Gluten, which is a composite of proteins gliadin and glutenin, and it comprise about 80% of the protein contained in the wheat seed, especially in wheats. And the gliadin, which is a part of the gluten, it is a glycoprotein present in wheat, as we say, and in other grains such as the rye, barley, and to minor degree oats. So, what happened here? Here is the gluten part protein inside the lumen of the GIT. It will be absorbed through the epithelial cells into the lumen, into the wall of the intestine. So what happened? The pathogenesis of the celiac disease is thought to be an abnormal permeability of the intestinal epithelium, allowing the entry of the gliadin. We say gliadin peptide of the gluten, which is not entirely degraded by the intraluminal and cross border bound peptides for one reason or another. So gluten peptide should be degraded to a gliadin, and the gliadin, after complete degradation, then pass through the intestinal epithelium by its permeability to the wall. But abnormal permeability toward this will initiate the problem. So this gliadin will be deamidated by an enzyme called tissue transglutaminase. So this enzyme converts some of abundant glutamines to glutamic acid. And I say deamidated. So what is deamidation? Deamidation is the process of hydrolysis or removal of amide group, which is an organic compound found in the side chain of the amino acid asparagine or glutamine. This tissue transglutaminase enzyme has been discovered to be the autoantigen against which the abnormal immune response is directed. So this deamidated gliadin, after deamidation and removal of amide group by the tissue transglutaminase, is presented to T lymphocyte by the antigen presenting cells expressing the HLA genotype. Then this will lead to what? This will lead to autoreactive T lymphocyte causing injury to the small bowel mucosa, to the skin, to the liver, joints, brain, and other organs. So this will lead to further damage of the epithelial cells of the intestinal wall and more permeability for the gliadin, which is incompletely degraded, and this will lead to the manifestation of the celiac disease. Non-genetic factors linked to celiac disease include age at introduction of dose of gluten and intestinal infection that produce gut hyperpermeability. So the autoimmune process that is initiated by the T helper cells will increase, as I say, to more damage for the intestinal epithelium, and this will lead to intestinal infection, which will produce more gut hypertrophy. When I say there is a damage to the intestinal epithelium, this means lead to atrophy and removal of the intestinal villi and microvilli that normally and usually increase the surface area of the intestine. So this is simply what happened in the pathophysiology of the celiac disease, and here you just to understand what happened, not to keep it in your mind. Now what about the clinical features of celiac disease? You remember we say for the malabsorption syndrome, the clinical feature will be gastrointestinal manifestation and extraintestinal manifestation. So, classic celiac disease characterized by classical GI manifestation with signs and symptoms of malabsorption. Do you remember what they are? Celiac disease today recognized in all age groups, and classical presentation no longer present. If you think of the classical presentation of the celiac disease as a malabsorption, that means diarrhea, steatorrhea, abdominal distension, failure to thrive, this is no longer present. There is a non-specific presentation. It can occur at any age group, making the diagnosis of celiac disease is not so straightforward. So this picture shows the classical celiac disease. This is in black and white because these are the kids of celiac disease before. You notice here the abdominal distension, the failure to thrive, and the irritability of patients. But the celiac disease kids nowadays looks like these. They are just look like their peers, looks normal children, and happy and playful. So the manifestations of celiac disease as a multisystemic disease, and you remember I mentioned this as a causes of the malabsorption. It could affect the central nervous system. It could affect the mouth, the heart and the cardiovascular system, the liver, and of course the GIT, the bone, and even the reproductive system, leading to miscarriage, infertility, or delayed puberty. Now, what are the gastrointestinal manifestations? The classic form of celiac disease consists of GI symptoms, and the classic onset is between 6 to 24 months of age. Why? Because this is the age of usual introduction of gluten in the diet. So what are they typically? Chronic diarrhea less than 50% and or steatorrhea, which means the excessive fat loss in the stool, abdominal distension, irritability, anorexia, and vomiting, weight loss or poor weight gain. And we have what's called the celiac crisis, which may be manifested, or maybe the early manifestation of the celiac disease. And here the patient comes with dehydration, hypotension, hypokalemia, and explosive diarrhea, but this is usually rarely to be presented. But for older children, more than 2 years, they may have chronic abdominal pain, chronic constipation, so not usually diarrhea, bloating, and diarrhea that mimics symptoms of lactose intolerance or inflammatory bowel disease. Irritable bowel syndrome. That's mean constipation and diarrhea. What about the extraintestinal manifestation? These are like more in older children and adolescent patients. Dermatitis herpetiformis, which is the most common presentation of the extraintestinal manifestation. It happened in 15 to 20% of patients of celiac disease, and in 85 to 90% of patients with dermatitis herpetiformis, they have celiac disease. So, for us as a pediatrician, we can find the dermatitis herpetiformis in about 15 to 20% of patients with celiac disease. But for the dermatologist, if they notice a patient with dermatitis herpetiformis as the primary presentation, so they should think that in 85 to 90% of them they have celiac disease, and the primary or underlying problem should be searched. So that's why dermatitis herpetiformis is a specific for celiac disease. Other manifestations: iron deficiency anemia, hepatitis, aphthous stomatitis, alopecia, short stature, delayed puberty, infertility. We have a group of manifestation related to the calcium deficiency and the deficiency metabolism and the deficiency of the vitamin D3, like osteopenia, rickets, dental enamel defects, secondary hypoparathyroidism, arthralgia, and arthritis. And we have the group of the manifestation related to the CNS, like headache, depression, cerebellar ataxia, and peripheral neuropathy. So the presentation is not specific, involve most of the system of the body, not just the GIT. This is making the diagnosis is a dilemma. Now these pictures show the dermatitis herpetiformis that found at the back of the neck and the shoulder, or at the extensor surfaces of the knee joints, or the external surfaces of the elbow, as you see here. And this is aphthous stomatitis, and this is the dental enamel defect, as you see here. And now we will talk about the diagnosis of celiac disease. How can we diagnose this problem? It can be very challenging to diagnose, and now you know why. Because of the non-specific presentation, and the patient not develop the classical manifestation. Celiac disease, and it's very challenging to diagnosing because it can be misdiagnosed as inflammatory bowel disease or lactose intolerance, and the classic presentation, as we say, no longer present. So increasing the understanding about celiac disease, it will increase the rate of diagnosis. Firstly, by lab finding. What can we do to reach the diagnosis? By using lab finding after initiating the taking history and performing the general examination. Firstly, serologic and genetic testing. We say it is an autoimmune, so there is an antibodies that is specific to this disease. Screening test exists with excellent sensitivity and specificity. IgA, anti-tissue transglutaminase, and IgA, anti-endomysial antibodies are done in IgA sufficient patients. In those patients, because they may have other autoimmune disease, so the IgA may be deficient or IgA may be sufficient. So for those with sufficient, we will do the anti-tissue transglutaminase and anti-endomysial antibody based on the IgA level. So we should do IgA level at the same time to see if it is sufficient or not. But those with insufficient IgA, we can do the IgG based anti-tissue transglutaminase and anti-endomysial antibodies in the presence of IgA deficiencies in those patients. And previously we have what's called the anti-gliadin antibody test, but this is no longer used. You know, the gliadin, which is the composite of the gluten protein of the wheat and other grains. Now we will go to the genetic testing for the HLA-DQ2 and DQ8, and you remember the percentage for those patients. So this has a high negative predictive value, not like the serology. We say in serology it has excellent sensitivity and specificity, so screening test is essential. But here in the genetic testing, it has a high negative predictive value and is useful in assessing the risk for celiac disease in family members, but not for screening for the presence of celiac disease. So if you have a patient with celiac disease, you can do genetic testing, if it's available of course, for other family members, because you know now the association with the first degree relative. But as a screening test, if you suspect this is a celiac disease, it is not a good screening test because of the high negative predictive value. After doing the serology and genetic test, the stool is important because we will have we will see a partially digested fat and maybe acidic because of the deficiency of lactase enzyme. Hypoalbuminemia may be a manifestation because of the malabsorption of the protein, of course. And anemia, and we mentioned that the anemia could be iron deficiency anemia or folate deficiency anemia or B12 deficiency anemia. All types of anemia could happen. So we can, according to the blood film, we can check about the type of the anemia. Now, the mentioned before are not a confirmatory test for celiac disease, and the only confirmatory test for it is the biopsy finding. So doing a jejunal biopsy is the only confirmatory test for celiac disease, and the patient before doing this should remain on diet containing gluten until the biopsy is performed to see the effect of gluten on the villi. And the finding characteristically taken from duodenal biopsy is the villus atrophy with increased number of intraepithelial lymphocytes. But up to 10% of celiac disease eating gluten have false normal level of tissue transglutaminase enzyme IgA antibody. So an endoscopy and biopsy may be still performed in cases of pronounced signs and symptoms. What does this mean? We talk about the high sensitivity and specificity of TTG IgA antibody, but this say that up to 10% of those they have false negative, false normal level. But if you have more pronounced signs and symptoms of celiac disease, you may do endoscopy to reach to the final or definitive diagnosis. So this picture shows the difference between the normal intestinal mucosa. Here is the villi and the microvilli, and here is the abnormal, that is atrophied villi, and formation of a crypt, or can we say this is a crypt hyperplasia, and this will increase the permeability of the intestinal lumen into the gliadin to be passed to the wall of the intestine and receiving it by the tissue transglutamase, which present it to the T helper lymphocyte system. And this is a real picture from the biopsy, showing the difference between the normal intestinal biopsy and small intestinal biopsy in patients with active celiac disease. Now we have three definitions we have to know. Silent or asymptomatic celiac disease. Now you know the symptomatic celiac disease, they have symptoms, clinical features, serology test positive, genetic test positive. So what about the silent? In silent, from its name, there is no symptom, asymptomatic, but there is a positive serology test, positive biopsy, and CD or celiac disease HLA genotype. All investigations are positive, but there is no symptoms. So in most cases of silent celiac disease, they can be identified by serologic screening in at-risk group. This means a first-degree relative or twins, or they may have autoimmune diseases like autoimmune thyroiditis or IgA deficiency, or they are of Down syndrome or Turner syndrome or type 1 diabetes mellitus. So you think they may have celiac disease. Sending them for the screening, they will be positive. So what we call this? We call this silent or asymptomatic celiac disease. This is the first definition. And now we will talk about the potential celiac disease. What about this? In potential celiac disease, there is a normal mucosa in a person at an increased risk of developing celiac disease, as indicated by positive celiac disease serology. So here it's mean by biopsy, by duodenal biopsy, the mucosa is normal, but there is a risk to develop later on celiac disease because the serology is positive. This is mean tolerance for the autoimmune process. The third term is the latent celiac disease. And what does this mean? In those positive celiac disease HLA genotype, but the biopsy is normal and the serology negative, and of course there is no sign or symptoms of the disease. This is called latent. They may develop the sign and symptoms later on. At the same time, they may develop abnormality in the biopsy or positive serology. So just the positive in them and latent is the celiac disease HLA genotype or genetic tests. Now, nowadays you hear a lot about the iceberg phenomena of the COVID-19. That means the discovered or the confirmed diagnosed cases is much less than the real cases in the society. The same thing can be applied in the celiac disease. As you see here, the iceberg, the apparent part of it is smaller than the hidden part, of course. So that's why Titanic ship was hit and destroyed completely. by it. So the upper part is the symptomatic celiac disease. They have the symptoms and they have the mucosal lesion, and of course the HLA type positive and the serology positive. The silent here is hidden. In silent there is no symptoms, but the mucosal lesion positive. And in latent disease, the mucosa is normal, but just the genetic susceptibility are positive, and the serology will be positive later on. Now, how we approach to diagnose celiac disease? On the previous slides, we know the tools of examination, tools of investigation, but we didn't know what is the approach to patient of celiac disease. What are the steps we should follow to reach to diagnosis? Now we will know. Follow this pathway. So if you have a patient with persistent diarrhea, failure to thrive, persistent GI symptoms, or short stature, delayed puberty, and dental enamel defects, and persistent anemia, they are the intestinal manifestations. Or if you have a first degree relative of celiac disease, or your patient are diabetic or has thyroiditis, or he is Down syndrome, Turner syndrome, or Williams syndrome. So what you will do for those group of patients with manifestations or with risk factor? We will do tissue transglutaminase, IgA, and total IgA, if you remember, to see its level. So if the result is normal, so this is unlikely to be celiac disease. But if the result is abnormal, here you can consult gastrointestinal endoscopic duodenal biopsies, and you send for the histopathology. So if the histopathology is normal, so what you consider here, this may be potential celiac disease because just the serology is positive. He may develop the abnormality later on, and you have to review the pathology and monitor and repeat the serology and consider repeat biopsy or genetics accordingly. But of course, if the histopathology is positive, so this is a confirmed case of celiac disease, and you have to go directly to the management, which is the gluten-free diet, and we will talk about this later on. Now, can we go directly for the management, which is a gluten-free diet, without doing, skipping or bypassing the histopathology? Can we do this? Yes. In which cases? In which cases we can do this? We will know now. According to ESPGHAN, which is the European Society for Pediatric Gastroenterology, and the Hepatology and Nutrition, their guidelines in 2012, they say the diagnosis can be established without biopsy if the signs or symptoms suggestive of celiac disease, or the tissue transglutaminase is more than 10 times upper limits of its normal value, or the anti-endometrial antibody is positive in second blood sample, or HLA typing test is consistent with celiac disease. They say that doing or establishing the diagnosis without doing histopathology or jejunal biopsy. They mentioned here active symptoms highly elevated, are positive endotomy and consistent HL typing, go directly to the gluten-free diet. Now, what is the differential diagnosis of celiac disease? Firstly, it could be food allergy, Crohn's disease, inflammatory bowel disease, post-infectious diarrhea, immune deficiencies, a graft versus host disease, and hypergastrimia or Zerlinger-Ellison syndrome. Now, what is the treatment of the celiac disease? You know, the treatment is very simple for us and is very difficult for the family they have patients with celiac disease. Why? Because it's very difficult to be applied. You know, the gluten, as we said, it's found in many of the food, in baked goods, and in other containing the grains like wheat, barley, and rye, and to some extent the oat. And sometimes the new gluten is found as a micro constituent of food. That's why if you hear, even when you are traveling by plane, they ask you, are you of gluten sensitivity, enteropathy, or celiac disease, and they supplied you with a gluten-free diet. But who discovered the relation between the gluten as an extrinsic triggering factor and celiac disease? This is discovered by Dr. Willem Karel Dijk, which is a Dutch pediatrician, and this has happened in the famine during the World War II, the Dutch famine. This doctor noticed that when the delivery of the bread to the inpatient children in his hospital, they paradoxically improved and the symptom relieved. But after the famine, after the cessation of the war or the fire, the symptoms relapse after the supply of the bread again. So he noticed the relation between the gluten and between the bread at the beginning and the manifestations of celiac disease. Then he specifically concentrate on the gluten part of the wheat and other grains. And from that time, the gluten considered as the triggering factor for the celiac disease. You remember the definition: autoimmune, triggered by gluten, in genetically predisposed patient. So the dietary gluten restriction is for life. If you hear in practice someone advise the parents to stop the gluten for just a few times for several months and then to reinitiate it in the feeding, this is absolutely wrong. When we are sure of the diagnosis of celiac disease, the restriction of gluten will be for life. All sources of wheat, rye, and barley should be eliminated. Most, but not all patients tolerate oats. We mentioned this before. So, what is the changes that happened after removal of the gluten from the diet? The intestinal mucosa should normalize by 6 to 12 months, while lactose intolerance resolves often within a few weeks. Can we follow our patient that is diagnosed as celiac disease by serological tests? Yes. After 3 months, if we repeat the serological test, we may find a decrease, the titer will decrease after removal of gluten from the diet. So, supplemental calories, vitamins, and especially the fat-soluble vitamins and minerals are indicated only in acute phase of the diagnosis of the disease. And because celiac disease is associated with hyposplenism, and why the patient of celiac disease have hyposplenism? They are this is because of the chronic folate deficiency and because of excessive loss of lymphocyte through the damaged GIT. This will lead to a reduction of the function of the spleen. So these patients are at an increased risk for invasive pneumococcal disease and should receive the pneumococcal vaccine. And as I said, the celiac disease related antibody titer decrease within 3 to 12 months of a gluten-free diet. So we can repeat the investigation, repeat the serologic test after at least 3 months, and this could be regarded as a challenging test. When you stop the gluten for 3 months, then repeat the test to see the difference and the improvement in the results. Of course, the management of the celiac disease, it's not performed just by the pediatrician. In Western countries, they initiate a team for the management of the celiac disease, and this team composed of pediatrician, of dietitian, of social work, and of medical provider, and they have a group called the celiac support group. They did it for celiac disease and for other chronic diseases, and this is making a gathering of families, of parents. They have celiac disease patients or other disease, and all of them at a frequent meeting will present their problems with the disease, how they diagnose it, how they follow the plan of management, what are the ways of compliance for the management of the disease, and whether there are the occasional problems that may happen in this patient or not. And this is what's called experience exchange between the families or the patients with celiac disease. So it is a very comprehensive management doing by these groups of support and by the medical team. The gluten-free diet is a right for all patients with gluten sensitivity enteropathy or gluten sensitivity problems, even if they are in jail. So as you see in this comic picture, he is very miserable, but he asked for his right to eat a gluten-free diet. We talk about the celiac crisis, and we say it is rare and it is manifested by explosive diarrhea and hypotension and hypokalemia and dehydration. So in those patients, in addition to the celiac restriction of the gluten, we may introduce the corticosteroid, and this is indicated only in patients with celiac crisis with profound anorexia, malnutrition, diarrhea, edema due to hypoproteinemia, of course, abdominal distension, and hypokalemia. Now, what's the prognosis of patients with celiac disease? Enteropathy-associated T-cell lymphoma of the small bowel occurs with increased frequency in adults with long-standing untreated diseases. This is a remote possibility, but of a serious bad prognosis. And individuals with poor adherence to gluten-free diet may be at an increased risk of fractures because of the calcium metabolism and abnormalities and the vitamin D deficiency, for iron deficiency anemia, and for infertility, as we say. And these are all what you have to know about celiac disease. Hope it was clarified to you in a correct way and in a simple way, and thank you for your listening. See you in the next lecture. Goodbye.